just a little bit of feedback. Okay, so gestational hypertension, like I mentioned, is what we're going to talk about. We're going to talk about just mainly the recognition and management, and go through a case. And then hopefully we'll have enough time to answer questions and also talk about other cases that have happened recently with some of our clinic patients. So let's make sure my clicker wants to click. So putting in my little disclaimer slide, I didn't get paid any extra for this and don't have any financial interest in anything that I will be talking about. So just wanted to put that in there. Oh, my slides are not switching. Hold on one second. See, this is all new. Slideshow. Don't know what's going on. Hold on one second. Okay. Let me go back and restart it. And I'm going to stop sharing for just a second. And then I will share again. Having 3 screens is a little bit like doing traffic control, I feel like. So, okay. Let me get my PowerPoint back up and running, and then we'll go from there. And I'm beginning. Let's see if it'll want to go with me now. Now it looks like it's going to go. Okay. Let me get back into Zoom and share. Screen share. And we're going. Okay. So like I said, disclaimer slide that I don't get paid any extra for this. Just do this out of the kindness of my heart. No, just wanting everyone to hear about the topic more than anything. And okay, now it wants to do weird things again. Okay, so hypertensive disorders of pregnancy. About 12 to 22% of all pregnancies are affected by hypertensive disorders. And so that's going to encompass quite a bit of our patients when we're seeing them here in the clinic. And again, sorry, I'm having screen issues. It's wanting to not show me my screen. Okay. I'm going to actually put my computer, my video down for just a second since you guys are looking at the screen. So Jane is a 34-year-old. I'm going to actually go back one more screen. There we go. Hypertensive disorders are responsible for about 17% of all maternal mortality. And historically speaking, physicians actually identified the presence of albumin in the urine of pregnant women all the way back into the 1800s. So I thought that was kind of interesting. And that was actually before we were actually recording blood pressures, because the sphygmomanometer was not even developed until 1888. And then preeclampsia, as we know it, was later introduced as a means to recognize the time period where delivery could potentially be used to prevent the progression of to eclampsia. Let me get back to speaker view so I can see some things here. Okay. This is where I don't like multiple screens. I'm sorry. Now I've lost my PowerPoint. Oh my Lord. Okay, there we go. So we're going to go through a case. This is a OB case that's kind of going to be similar to cases we would see here in the clinic. So it's no one in particular. I just kind of made it up based on things that we see routinely. So this is Jane. She's a 34-year-old G2P1 at 32 weeks. She's coming in for an office visit. She's previously had an uncomplicated vaginal delivery at 39 weeks, and her BMI is 35. She did pass her 1-hour GTT, and other prenatal labs were normal. No history of preeclampsia or GDM in previous pregnancy. Today, her symptoms, she says she's having occasional Braxton Hicks, but they're not happening too often. And she denies any right upper quad pain, swelling, headache, vision changes, or shortness of breath. Of note, though, her vitals show a blood pressure of 148/92, heart rate of 87, and good fetal heart tones at 145 with measuring appropriately 33. Urine shows no protein and no glucose. So this is where we're going to try our first polling question. So let me see if I can, again, let me get out of my screen view. Sorry. I need my, okay. Let's see here. There we go. So polling question 1. I'm going to launch it, and then I think from what I understand, you guys I'll give you some time to answer, and then we'll share the results. So try it out. Again, I don't even know what it looks like on your side of things. So here's polling question 1. So hopefully you can do something with it. And if not, let me know. It looks like a couple people are able to vote. Pardon me. Give a few more seconds here. Okay, looks like we're figuring it out. Awesome. Okay, I'm going to go ahead and end polling on this one, and then I'll share the results. So the question was really about her follow-up and what we would do. And so good news is 8 out of, it said we had 12 people that were on, said that they would follow up in 1 to 2 days for a blood pressure symptom recheck. And I think that's perfect because we're concerned enough that her blood pressure is elevated. However, she's not showing any signs or symptoms of preeclampsia at this point. So we need to kind of establish what's going on and why her blood pressure is up. And we don't want her to follow up too far off in the future because we need to understand if this is going to be a sustained elevated blood pressure for her or not. So, and I'm going to close that and back to our screen. So let me go back to... So now on to kind of the meat of the matter is gestational hypertension. What exactly is this? So the ACOG bulletin that just came out, literally hot off the presses, was an updated one from the one in 2019, but the newest one is here in June about gestational hypertension and preeclampsia. So super pertinent to what we're doing. And the definition is really a blood pressure of 140/90 or both on 2 occasions at least 4 hours apart after 20 weeks of gestation in a person that previously had normal blood pressure. So women with gestational hypertension that have severe range blood pressures, 160/110, should actually be diagnosed with preeclampsia with severe features. And we'll go a little bit more into that later on, but wanted to kind of really hit hard the definition. Some interesting things that I learned as reviewing this, that gestational hypertension is associated with adverse pregnancy outcomes, and they're thinking it may not represent a separate entity from preeclampsia. And I think a lot of us think about gestational hypertension as kind of a spectrum, possibly with preeclampsia. Some people really, it's its own thing, but one of the articles I read quoted that up to 50% of those with gestational hypertension will actually develop proteinuria and other end organ dysfunction consistent with preeclampsia. And this is more likely to happen if they have the hypertension actually diagnosed before 32 weeks. So that's just important for us to know that we really have to watch these women. And the outcomes for those with gestational hypertension usually are good, but the fact that the one notion they said is that it is still, as concerning or should be followed, just like we would follow a patient with preeclampsia. So that's one thing we wanted to talk about. Okay. And I found this actually in an AFP article from a couple years back, and I liked it because it's pretty simple. but it really drives home that we really have to label hypertension in pregnancy. And so, you know, we get a woman in for whatever time in the pregnancy, and she has a blood pressure of 140/90. We really have to decide what's going on. And if we don't have enough info at the time, we have to do close follow-up so we can get more information. So as you can see, if she is less than 20 weeks in gestation and she doesn't have proteinuria, then she really is a chronic hypertensive. And I think a lot of times we have women that haven't really had any need for health care prior to their pregnancy. And so they don't know that they have hypertension until they come in for the pregnancy itself. So we do have to pay attention to that. If she has new or increased proteinuria, then we definitely have to think about she may be having preeclampsia really early in the pregnancy. That's a lot less likely, but it can happen, and should be, you know, we should get labs and kind of evaluate more. So that could be preeclampsia on top of chronic hypertension. And then what we see more often is really the after 20 weeks gestation. And we have the two kind of buckets. And we're going to talk about the one today, gestational hypertension. But remember, as we all know, preeclampsia is hypertension associated with proteinuria. I went ahead and built this table just because I feel like it is important to look at. I know there's a lot on here, but in basic terms, the basic definition of preeclampsia and gestation is gestational hypertension for the blood pressure is the same. So there's no difference there. The biggest difference really comes in the proteinuria, and I think most of us are familiar with that. The current ACOG guidelines break it into 3 ways to designate you know, whether they have proteinuria. They do make note of dipstick reading of a 2+. I know there's a lot of residents that talk about, oh, they've got trace or 1+, and they say to only rely on the dipstick if we don't have other methods. And here we have other methods. So we should really be aiming to get a good collection of urine to make sure we know what their proteins, you know, really is. As far as gestational hypertension, usually they're not going to have other symptoms. And when you read the literature, and especially the newest ACOG bulletin, if those symptoms develop, then they really should be defined, and those symptoms would be here, they should be defined as severe preeclamptics. So that's where we have to be kind of clear asking about symptoms, but then the terminology changes as soon as those symptoms occur. And then management subsequently would change for those women. This also was a table out of the ACOG bulletin. I put it in because in general, gestational hypertension doesn't have great prevention techniques, except for the fact that if we can reduce or modify their risk going into getting pregnant. So our diabetics, our hypertensives, and really patients really more at risk for those diseases. So obese patients, or family history, you know, kind of talking to them about being as healthy as they can be prior to pregnancy. But this table is included because if we have someone with some of those risk factors already, then they really should be considered for low-dose aspirin throughout their pregnancy to prevent preeclampsia, which could be obviously an offshoot of gestational hypertension. So following up our case, so Jane returns for follow-up in 2 days, basically like you guys said, which was awesome. And her follow-up blood pressure now is 144/88. Baby still is looking good, and she still has no protein. I'm going to go to polling question number 2 here. Let's see if I can get to it. Sorry. Where is my Zoom questions? This is where I get backward a little bit. Hold on. Here we go. Okay. Polling question number 2. Let me relaunch polling. And sorry, I have to relaunch a new question. There we go. Okay. So here's our question. What would your management be for Jane's condition at this point? And hopefully people are able to read those and make a decision. like we've got a majority of people voting. So I'm going to go ahead and end polling and share results. So it looks like the majority, I know there's a lot to read on the question answers, but voted for all of the above, which is perfect. So we're going to go through that. Each of these are important for monitoring our patients with gestational hypertension. So we're going to kind of go through that. And now my computer wants to freeze a bit. Sorry. To kind of show you a little bit, I don't know if everyone can mute and get a little bit of sounds in the background, but to show you what the outpatient monitoring really needs to be for gestational hypertension, I feel like sometimes I need people to think about the, what the actual kind of need for follow-up is. And so for our women with gestational hypertension, they're going to actually need kind of four big things. They're going to need an evaluation of fetal status, and that's with the antenatal testing. The options are either twice weekly NSTs or weekly BPPs. The recommendation for gestational hypertension is to start that at 32 weeks. Or whenever they get diagnosed. So if they don't get diagnosed till 34 weeks, that's when you would start. And then the next thing would be weekly labs, CBC, CMP, LDH can be used as well. That was brought up in the ACOG article as something that they're kind of bringing back to monitor our patients that could possibly become preeclamptic. And then a urine protein creatinine ratio, either the random or the 24-hour urine. They also need weekly office visits. So even though these patients may not typically be due for weekly visits yet in their pregnancy, they actually do need weekly office visits. That's for blood pressure check, symptom check, and weight monitoring, and to make sure that there's no new symptoms of severe features. The other thing that they recommend is ultrasounds for growth and fluid, and making sure that those are happening roughly every 4 weeks, and that those were mainly monitored. Okay, we've got people honking in the background. I'm going to see if I can mute everyone for a second. Again, I'm not good at all of these controls, but let me see here. Okay. And I thought I knew how to do that, and now, oh, here we go. Okay, people are muted, I think, at this point. Okay, perfect. And so really this is the hallmark of this talk, to really talk about that we need to be kind of doing all of this for our gestational hypertension patients, not just for our preeclamptics. So we want to make sure that that's something that we're looking at. So the next case is Jane comes, or not the next case, the continuation of the case. She comes in and she is now labeled as gestational hypertension. You've had her come in for weekly office visits and labs, NSTs twice weekly, and she had her ultrasound at 34 weeks. Now though, she's found to have a blood pressure of 152/90, and she did notice some increase in lower extremity swelling. But denies any other symptoms and feels like she feels good otherwise. And protein in the urine was just trace. So we're going to go to polling question number 3. And let me stop share. Okay. Launch polling. Let's see if I can pull that over. There we go. Okay, so polling question is going. And the big question now is what we do for delivery and what's our recommendation. And there is some debate with this, so. I'll let a few more vote. Okay, we'll end the polling. And I'm going to share results here. So looks like the majority said she should be scheduled at 37 plus 0 for induction. And we're going to go through the next slide so you'll kind of see that ACOG supports that. That is definitely what ACOG recommends. The debate, though, is that the Society of Maternal Fetal Medicine says that they can be delivered anywhere from 37 to 38 and 6. And so delivery-wise, a lot of times that if they're stable and they're having just what they say mild hypertensive kind of management, then they can actually wait till 38 and 6. Again, sometimes this is where we have to talk to Landwehr and get a clarification. But on a recent patient of ours, I actually discussed this with him, and he had recommended the 38 to 38 and 6 range for her. So that she wasn't preeclamptic, had all negative labs. But they definitely really need to be delivered before that 39 weeks, and 38 and 6 is kind of the cutoff for the literature. So we're going to go to the next slide and I'll kind of show you. So this is the timing of delivery recommendations that are out there right now. So this is where the debate comes in a little bit. ACOG says, quote, continued observation is appropriate for a woman with a preterm fetus if she has gestational hypertension or preeclampsia without severe features. And in a woman with gestational hypertension or preeclampsia without severe features at or beyond 37 and 0, delivery rather than expectant management upon diagnosis is recommended. So one thing I did clarify with Dr. Landwehr when I called him the other day is if we have a woman that gets diagnosed with gestational hypertension prior to 37 weeks, and her blood pressures she's not requiring meds, she's relatively well controlled without anything, what would be his recommendation for delivery? And he falls into this 30 up to 38 and 6 for that patient. And, without getting lots of details from him on, would there be other reasons to deliver her early? Obviously, any concerning symptoms, probably those that are requiring medication to manage, that may be something that would increase or decrease the time that you would want to keep her pregnant. But there are different schools of thought. So like I said, the Society for Maternal Fetal Medicine says 37 and 0 to 38 and 6. There was a consortium called the Consortium on Safe Labor that was conducted a couple years back, and they actually found that induction of labor between 38 and 39 weeks of gestation kind of was that nice balance between the maternal risk and the neonatal risk or morbidity mortality. And so I think that's where Dr. Landwehr, when we chatted, that's kind of where he falls also. So again, I don't think we would be wrong to deliver at 37 based on ACOG, but I do know that he even said we're experiencing more patients with babies that come out and need to be in the NICU, and if they are, have mild gestational hypertension, waiting would have been fine. So there are a few conditions, and I think this really makes sense. These are all the conditions. This would be anything that would mark her as severe. So anything where her blood pressure started going high, headaches, right upper quad pain. So anything that we would all of a sudden designate her as having severe features, then she couldn't wait. We can't wait anymore. So we need to deliver. The same goes with the fetus. If there's any abnormal fetal testing, fetal death would make sense, of course, but if there was anything that we felt there was at risk for the baby, we would not want to keep her pregnant anymore. So I think most of us know that. The one thing that I got out of the literature is just that, that evolution to preeclampsia is real. I think that's why we're monitoring and why we need to be monitoring these patients very well, because they can develop preeclampsia. And in a woman that does get blood pressures in the severe range, the 160 over 110, she then is considered preeclamptic even without protein. So remember that, sometimes and we'll go through this case as it continues, but sometimes we get still really hung up on the protein idea, and by definition, ACOG says if she develops severe pressures, then she should be labeled as preeclampsia with severe features. Anytime she does develop the proteinuria, though, then she gets kind of relabeled as preeclamptic. And so one thing, recently I was in discussion with the residents, we were talking about a case, and it kind of went back and forth because the protein actually initially was marked as high, but a repeat cath one was actually in the normal range. But we talked about like relabeling the patient, and would that change our management? And sometimes it will. So we definitely want to make sure that we update the problem list, we update the plans for her based on the changes. So continuation of Jane's case, she's now coming in. You've decided to do her induction at 38 and 2. She's had stable blood pressures. She's not been on any medications. Labs and weekly testing have been good. You've elected to place a cervical balloon because her bishop is 5, and admitting her, blood or labs and fetal heart tones are reassuring. Initial blood pressure at admission is 142 over 88. So everything is checking out pretty good. However, overnight, the nurse calls you, and now she's got blood pressures of 172 over 90 and 178 over 95. So we're going to go, we've got 2 polling questions for this one. And let's see, launch. Pull that back over. So what is your management of Jane's elevated blood pressures? Okay, go ahead and we've got most people voted. I'm going to share the results. So the majority chose kind of what I would choose, which is actually giving orders for IV labetalol or IV hydralazine based on our OB hypertensive order set. That's because the newest recommendations from ACOG really support I say more emergent or faster treatment of the elevated blood pressures than we used to. And so that's something that is a change. I think you guys in training are getting that kind of right up front as you're learning it. But in the past, we wouldn't have necessarily treated that when we were residents. And so that's something that is a change. That committee opinion by ACOG, it was back in 2019 on emerging or hypertensive emergency is really where that's coming from, and a lot of the studies that kind of went around that. So we're going to stop sharing and pull over here. And then question 5 is also part of this. So I'm going to launch. So what should you do? What should you also do for Jane? This is again based on the newest ACOG recommendations. Pardon me. Okay, I'll go ahead and end and share the results. So looks like a majority of you chose what ACOG would want you to choose, which is go ahead and start magnesium, because by definition, she now meets criteria for preeclampsia with severe features. And in those patients, we should be treating with MAG. I do know that in like practice, sometimes that's not being done. I think the complicating factor is people feel like she's in labor, she's going to have her baby soon. Do we have to do all of that? But we really should still be treating as a severe preeclamptic and starting the magnesium because we know that it can be protective against seizures, and we definitely don't want our patients to become eclamptic. And so that is something that should be done. Whether we're doing that all the time, I would say I don't know. So that's something we may want to discuss after the slides. The ordering labs, I think, is actually a good part too. You know, at time of admission for a patient with gestational hypertension, you should have a set of labs drawn to know where we're at time of admission. If she develops new symptoms or higher blood pressures, then I think repeating labs is probably a good idea. But I don't think that repeating the labs should preclude you from starting the MAG. So definitely wanting to make sure you get the MAG started. She doesn't need a C-section yet. I think we all recognize that. And, you know, the epidural, while it might help her relax, it probably won't fix that blood pressure because it's not probably blood pressure just from pain. And she's early in her induction process, so probably the pain is not really at the point where we would account for a lot higher blood pressure. So let me go stop sharing those. And okay. And so I think we're pretty familiar. I know this has been, obviously, like I mentioned, a change for all of us over the last couple of years. The intrapartum management of hypertension, and especially severe hypertension in our OB patients has gotten a lot more, you know, kind of, we do a lot more management of it than we used to. This is pulled from ACOG as well. And the order set that we have now on the floor tries to mirror this and give the nurses some steps. I know that they're working on, like, as a system, improving that to make it a little bit easier for the nurses to use. But both labetalol and hydralazine can be options. Kind of both of them have some, you know, kind of side effects or potential side effects. And time of action is a little faster with labetalol than the hydralazine, so just be aware of that. And sometimes nifedipine, the immediate release, could be an option too. If the antihypertensive should be used, one thing that was pointed out multiple times in the committee opinion about treating hypertension is not waiting 4 hours to basically say, oh, now they're severe, because that 4-hour mark is just to diagnose whether gestational hypertension or preeclampsia is there, but it doesn't have anything to do with diagnosing severe hypertension or severe preeclampsia, I'm sorry. And so being aware that we don't want to wait very long. We can always ask for a repeat blood pressure, but it probably should be a repeat blood pressure in 10 to 15 minutes if we get like the first one that's high. And then if we have two that are high, we need to proceed with treatment and know that it's real. And so that's one thing that I know sometimes doesn't always happen. So we're trying to educate the nurses as well as everyone, all the docs, to be doing that. So Jane has her baby. Good news is we started her on MAG because she did have the preeclampsia with severe features, treated her with IV labetalol. She delivered vaginally about 10 the next morning. And then her postpartum blood pressures, she had an initial one that was a little high, then it kind of came down, and then that following day, blood pressure was actually normal. So we're going to go to the next polling question, the last one here. And I'm going to pull that over. So what is our current recommendation for postpartum follow-up for Jane? Okay, we'll go ahead and end polling, and I'll share results. You guys are rock stars. So everyone agrees that an office visit in 3 to 5 days due to her hypertensive disorder in pregnancy is warranted. And what I wanted to drive home is she did end up with severe preeclampsia, but
even a patient that doesn't end up with that, but just has gestational hypertension in pregnancy needs that close follow-up. They still are at high risk for postpartum preeclampsia, and so we want to make sure that we're doing close follow-up. ACOG, I'll go to the next slide, but ACOG officially says 7 to 10 days from delivery. So what that ends up being, and kind of what our hospitals like OB peer review talked about, was a 3 to 5 day follow-up, just to make sure we're encompassing and getting them in soon enough, knowing that the weekends sometimes throw that off a little bit. Let me get this off. And so this is kind of what the current stance is, both here at our hospital and, like I said, what ACOG says. One of the things that I read did say that women with gestational hypertension tend to become normotensive within the first postpartum week, which is great. A lot of them aren't requiring long-term medications. And then women with preeclampsia tend to take a little longer to resolve their blood pressure, and that may be, you know, because of endothelial injury. They're not 100% sure. They do know that about 15% of these women will go on to develop or be diagnosed with chronic hypertension, and that's defined that as hypertension disorder or hypertension that lasts past the 12-week mark. So, and supposedly, I don't know that any of us go back and change our charting, but if that hypertension, gestational hypertension, resolves by 12 weeks, then what they had in pregnancy should be labeled as transient hypertension of pregnancy. Honestly, that's not a term that most of us use, and I don't think that I would go back and chart differently. But if you had a follow-up visit with her, you could make note of that. And it really wouldn't change long-term management, except for the fact that she's not going to be hypertensive to follow. And in future pregnancies, you're still going to have some risk factors for developing preeclampsia. But so I thought it was interesting to kind of relabel her as transient hypertension in pregnancy. The big caveat is, remember that these women do need aspirin for future pregnancies. A lot of times talking to them about making sure they're getting care early in their pregnancy so that they will get in. You can talk to them about their risk factors and then get started on aspirin appropriately. So. These are my references. I did forget to leave out the AFP article that I got one of the slides from. It was from a few years ago, pretty much encompassed a lot of what the ACOG practice bulletins have, but I wanted to, these are good resources. I normally do not love up-to-date for OB stuff. I find that it sometimes can be skewed a bit. And not as up to date, but actually for this topic, we've reviewed all of their stuff, and they did a pretty nice job of putting everything together. So I actually like their up to date, and that was most recently updated by them at the end of December. So I felt like it was fairly up to date on that. So